Hi everybody, Dr. Hall here. We're going to move on to our next unit, which is public health data and communications. So this is unit 3, and so these are the main topics that we're going to talk about. So what is the scope of health communications? What do I mean when I say health communications? And then where does the data that we get for public health, what are the different sources of that data? Where does it come from? How do we get that information? And then how do we measure the health of a population? So what are the metrics that we most commonly use to describe the overall health of a population? And then how do we present that health information to others? And we're just going to do a little piece of that, but that is a huge field of its own and worthy of an entire course. Then we'll talk about how people perceive health information. We actually know a lot about the factors that influence how people are going to take in that information, and then how they combine that information in order to make decisions about healthcare, and how also on the public health side, public health workers combine information to make decisions and recommendations, and then the different ways that we make decisions in individual healthcare. We're going to talk about that a little bit at the end of the unit. So this is how the textbook kind of lines this up, right? So we collect information, we collect and acquire data, then we compile it and analyze it, put it together, try to figure out what it's telling us. Then we present it, and then the people to whom we present it, or the groups to whom we present it, then perceive it, combine it with other information that they have, and use it to make decisions. So I like that graphic, but I also wanted to kind of point out that there's really two different sides of the equation here. So on the one side, the public health institutions and the data scientists are collecting, compiling, and presenting information, right? So that's kind of the scientific side of things, the worker side of things. And then on the other side of things are the people who perceive it, combine it, and utilize it for decision making. So there's really kind of two different groups of people who are doing these two different sets of things. So I've divided the lecture for this unit into two. So the first one, this one, we're going to talk about collecting, compiling, and presenting the information. And then the second one will do how we perceive, combine, and utilize information. So let's get started. So where do we actually get this information from? What are the data sources for public health? How do we know what's going on, right? How do we assess the problem? So what are the different tools we have for acquiring information? Sorry, I kept talking as I transition slides. I need to remember not to do that. So the book talks about the 7 S's, the 7 sources of data, and I'm going to go through these one by one to give you some examples of them. Obviously, you never have to memorize anything for this course because everything is open book, but I want to make sure you understand what each of these are, and given a particular study or finding, that you're able to identify which type of data source that is. So a single case or a small series, right? So this is like a report, like, oh gosh, this thing happened and we think it might be due to this. So I thought it was really interesting to look at the initial reports from the very beginning of the COVID-19 outbreak, before we called it COVID-19, before we knew what it was. So this is the initial report to the WHO. So you can see on the 31st of December, 2019, the WHO China office was informed of cases of pneumonia of unknown etiology, so unknown cause, detected in Wuhan City in Hubei province. And as of the 3rd of January, they had 44 people, right, of this strange pneumonia. And of those 44, 11 were severely ill. And then they said, according to media reports, right, there was a market that they were worried about. So they had closed that down to sanitize and disinfect it. And so they say the causal agent hasn't yet been identified, right? So this is kind of like with Legionnaire's disease, where at first they didn't know what was causing it. And so they have to do a whole bunch of laboratory studies to try to figure it out. And then I think it's interesting, so this third paragraph down was really huge actually in the beginning. So they say that clinical signs and symptoms are mainly fever, with a few patients having difficulty in breathing and some chest x-ray abnormalities. And so when eventually the pandemic was declared, we were told, interestingly, that fever was a necessary part of what's called the case definition. In order for you to say that you thought maybe somebody had this new strange illness, they must have fever. And I remember this very poignantly because we actually had a student who had returned from China after winter break who presented to the health center not feeling well and with a cough, but didn't have a fever. And so we said, well, it can't be COVID at that time. We weren't calling it COVID, but it can't be this thing because you don't have a fever. So we were wrong. It did end up that that person didn't have COVID, just so you know, they did eventually get tested, but we could have made a big error there because our information was incomplete. All right, but I digress. So I want to point out another thing that we later knew better, right? So they're saying in the last paragraph here that they were concerned that it was something happening in the seafood market. And then based on the preliminary information, no evidence of significant human-to-human transmission. Right? So early on, they were thinking, oh, well, maybe this is something that they got from some kind of infected animal in the market or something. But early on, they did not yet have evidence that one person had transmitted it to another person. Obviously, that was wrong, and there was massive human-to-human transmission occurring, but it takes a little while to know that. So in the very beginnings of the COVID pandemic, we didn't know that it could be a pandemic. So we didn't know that humans could transmit it to each other. So it's kind of chilling to look back historically and see how much we didn't know in those early days. So it is with science. So that's an example of a small series, right? A small series of cases. Highly informative, but incomplete information. And some of it's inaccurate. All right, so the second S is statistics, and there are multiple different types of statistics that public health officers will use. So vital statistics are like the really vital important things. So birth and death certificates, right? So we keep registries of births, registries of deaths. The death certificate has to say that the cause of death, contributory factors to that death, so that we can kind of get information about what's going on at the most basic black and white level with our population. Then we also have a number of diseases and conditions that are what are called reportable. So with a reportable disease or condition, if a physician or a laboratory diagnoses a certain condition or suspects a certain condition in a patient, they have to report it by law to the health department. Now, the reason for this is because these are diseases that are of great interest and potential risk to the population at large for one reason or another. And so we're going to get the public health system involved to help us with that. I'll talk more about that in a second. And then accident and police reports, right? So certainly when we're looking at the methamphetamine problem, for example, police reports are really helpful for us to get an idea on how many meth addicted people we have in our communities, for example. They're not necessarily coming to the doctor and getting diagnosed there, right? So we're going to use police reports. I want to circle back to those reportable diseases. So the reason why we have this is it allows a couple of things to happen. One is it allows us to collect data and information about these conditions and kind of know what's happening with them within our populations. But the other is it allows us access to additional resources. So for chlamydia, for example, that's a reportable disease. And the main reason why it's a reportable disease is because the health department wants to make sure that everyone who has chlamydia or potentially has chlamydia can get tested and treated regardless of whether they have health insurance or not. So if you've been exposed to chlamydia and you don't have any health insurance and you don't have a regular doctor, you can get tested and treated through the health department for free. right? So they're just there to help you out. They'll also do case or outbreak investigation and contact tracing if necessary. So many of you have had interaction with contact tracers, but to continue with the chlamydia example, if, for example, I get diagnosed with chlamydia and maybe I've had 5 different partners in the past couple of months that were potentially exposed, but maybe I'm super embarrassed about it and I don't want to have to call them and say, hey, guess what? I might have given you chlamydia. The health department will notify those people for me without disclosing my identity. So it's kind of a nice way to kind of take away the difficult parts of notification of close contacts or people who are potentially exposed, make sure that they get identified, get tested, get treated if necessary. So it just helps us to control a condition within a population. So the requirements for reportable diseases and what is reportable varies from state to state. So you can look at the Wisconsin ones if you want, but in general, these are things that have importance at the community level. So anthrax, cholera, right? So there's a lot of these kind of scary diseases. Chlamydia is one of them because oftentimes people don't have any symptoms, and so we want to make sure, again, there's that embarrassment and shame factor, so we want to make sure that contacts get notified and assessed. Blue-green algae poisoning is actually a reportable condition, and then there are many, many others. There are dozens and dozens of these, and so this allows public health institutions to collect information and data as well as help assure that things are appropriately dealt with. In all of this data collection that public health agencies do, there is a huge emphasis on maintaining privacy of individuals. So even though, to continue the example, my mom just dropped something. To continue the example, if I was diagnosed with chlamydia, the health department would have my name and phone number and information. They're going to keep that confidential, right? They're not going to share that with my potential contacts unless I give them permission to. And so public health agencies in general are going to go to some pretty great lengths to make sure that people's privacy is maintained. So an example of this, let's do that right now. Okay. An example of this would be that as of December 30th, there were a total of 60 COVID-19 deaths in Dunn County. So it's gone up a couple of days since I recorded the previous lecture. If you look at the database, which you all have seen by now, you'll see that of the numbers that are listed for the different age categories, so they break it down by how many people within each age category, those numbers only equal 58 total, right? So there are 2 deaths for which they're not telling us the age group of the person. And the reason they're not doing that is because seeing, for example, a 1 pop up in the 40 to 49 age group for a certain date could potentially out somebody, right? It could potentially make them identifiable, right? If during that same week there was only 1 obituary of somebody that age from Dunn County, and maybe the obituary didn't say the cause of death, but now you could look at this and say, aha, you died from COVID, right? That is violating somebody's privacy. And so, so those numbers get suppressed in terms of giving you these characteristics about their age, for example. So it's been interesting over the course of the pandemic. In the very beginning, we didn't have individual counts for anything under age 70 because the numbers were very small. Once there are at least 5 deaths in a certain age category, then they will populate that number because then it's too hard for somebody to be able to sleuth out who is who. All right, so that was our second source of data with statistics that are collected by public health agencies. Our third source of information is surveys or sampling. So these are studies, projects that enroll volunteers to submit health information or get testing done, kind of doing a survey, going out and texting a whole bunch of people. So then that information can be aggregated and analyzed. A couple of examples of these types of surveys or sampling studies would be NHANES, which is the National Health and Nutrition Survey. Oh, I think it's evaluation survey. I left out a word there, which is this really amazing program where teams of researchers travel the country and they go around and they don't exactly just knock on somebody's door and say, hello, I'm doing a study. Could you fill out some paperwork and let me draw your blood and swab your vagina? But it's not that different from that. So they go out and they routinely sample the health of the population. They travel all over the country and they collect information and they collect test samples, blood work, urine tests, all kinds of things on people to sample and get an idea of what's going on. So for example, if you remember the prevalence data on chlamydia that I showed you in a previous lecture, that's from NHANES, right? So that's going out and just saying, hey, let's just test a whole bunch of people at this time and see what percentage of people have this condition at this time. Another example of a sampling study is All of Us, which I highly encourage you to check out. So All of Us is a new research program from the NIH, and you can volunteer to be a study subject. It's pretty easy. You can sign up online, give them a bunch of information about yourself, and then schedule an in-person visit for some blood tests and some basic body measurements. It's pretty fun. They give you, I think, $20 for doing it, and you can help contribute to research about what determines people's health over time. One nice thing about the All of Us program is that they share some of that information back with you. So they're looking at some genetic markers for disease. So they were able to tell me that I was likely to not mind the taste of cilantro, which is true. But they can tell you some other neat things about your body based on your genetics. So it's kind of fun to be a participant in that. A fourth type of data source is Sentinel monitoring, now, or Sentinel surveillance, it's often called. So a sentinel, just as a word, is like a scout, right? That's like a sentry, right? That is somebody who's posted guard and is keeping an eye out, right? They're kind of a lookout. So in public health, the way this works is kind of an early warning system. So certain locations will periodically test for certain conditions just to get an idea whether they're circulating at that time or not. So for example, most years Student Health Services has done this for the state Department of Health Services. They'll ask us to collect 2 flu swabs a week on various patients who have cold symptoms or symptoms that could potentially be flu. And these are patients that we might not necessarily otherwise do a flu test in because either we're not that suspicious that it's flu, or we think it's flu and we're just going to make the diagnosis clinically rather than with an actual test. We don't always actually test for flu. We just say, yeah, it looks like flu. So this allows the state to know when the flu season starts. For example, they have clinics all over the state collecting flu swabs regularly. Those swabs don't get sent to a typical diagnostic lab. They get sent to the state, and where the state is able to kind of do the analysis and also see what strains of flu they are and kind of get some ideas. Super helpful stuff. Next one is self-reports. So self-reporting of symptoms can be very helpful. And in fact, if you got the COVID vaccine, you may have signed up for V-Safe, which was an app on your phone where you could put in what types of side effects you had as a result of the vaccine. And it would ask you kind of daily for a while, and then it was like every week for a while, and then it's pretty random after that. So that's a way to get kind of self-reported data. We also have lots of other ways to look at self-reports of data. And I just want to point out that you need to be careful with self-reports because these are patients that are saying, this is what I experienced. And it may or may not actually have a causative relationship, to continue this example, with the vaccine. So if, say, I'm somebody who gets migraine headaches, and 3 days after I got my COVID vaccine, I got a severe headache. Is that really from the vaccine, or was I just going to get a severe headache anyway, right? Or perhaps maybe I felt a little bit of chest discomfort. Does that mean I have myocarditis? Probably not. That's an inflammation of the heart, which is a rare side effect of the vaccine. Probably not. Could it be? Maybe, right? So me reporting some chest discomfort, for example, it could be, but it might not be. So it's not verified information. So self-reports from patients need to be further evaluated and investigated, right, to give us actually useful information. So let's talk about VAERS, because it's in the news and being shared on social media quite a lot. So VAERS is the Vaccine Adverse Event Reporting System. And I really want you to understand how this works, because there's a lot of misunderstanding out there in the public. So this is raw information that is put in by anybody. It could be patients, their families, their physicians. I've put in VAERS reports for people who I felt pretty sure were having a side effect from a vaccine. They happen, right? But it's not verified or validated. And in fact, you can submit information anonymously. Nothing is fact-checked in VAERS, and yet it is made publicly available as a database. So it's a little problematic, because the conditions that are reported may or may not have anything to do with the vaccination. It can be a really useful tool though, right? So if I had a patient who got vaccinated a week ago and they just died in a car accident, I'm going to submit that to VAERS. Do I think it had anything to do with their vaccine? No. Could it maybe possibly have been? Did they maybe pass out while they were behind the wheel? Yes, right? So any death that occurs within a certain period of time, we're going to report that to VAERS, just to make sure, right? If all of a sudden they saw a huge spike in the number of car accidents that happened in people who had been recently vaccinated that was higher than the rate of car accidents in people who hadn't been recently vaccinated, then they would say, well, hey, maybe there actually is something causative going on here that we would not have suspected. And in fact, VAERS was really helpful in identifying that really rare blood clotting condition that can happen, that complication that can happen in some recipients of the Johnson & Johnson vaccine. So VAERS data can be really useful, but it also can be really misleading if you don't understand what it is and what it isn't. So for example, this was a news article that was one of the most shared news articles on Facebook this past year. 2-year-old baby died within 6 days of getting the second shot of the Pfizer vaccine in the clinical trials. And if you read the article, they will say, according to VAERS, right? And VAERS is, it's a website maintained by the CDC, right? CDC themselves say that this 2-year-old died. Well, no, actually. So it's true that there was a report submitted to VAERS that said a 2-year-old experienced some side effects and received the vaccine, experienced some side effects, and died. It also said they'd been hospitalized for over 2 weeks. So then they said, well, gosh, maybe they were sick from the first shot. And who gave this sick, hospitalized baby the second shot? What's going on, right? And it turns out, and then they pointed out, well, this is strange. Like, why is a 2-year-old getting vaccines when the trial was only in ages 5 to 11 at that period of time? And of course, the CDC investigated this, and it was a completely fraudulent report. There was a child who died. This child never got a COVID vaccine ever, as part of a trial or otherwise, right? But someone put this into VAERS. There's nothing to stop anyone from putting all types of fraudulent reports in VAERS. The fact that it's in VAERS does not mean it's real, number one, and it doesn't mean that it has anything to do with the vaccine, number two. Okay, so VAERS is just this huge net to try to catch everything that may or may not have anything to do with the vaccine, and we get a lot of garbage. There's a lot of garbage in data, a lot of garbage data in VAERS. Okay, so moving on. The sixth S is syndromic surveillance. So sometimes we'll look for symptoms of disease rather than specific diagnoses. For example, Wisconsin Department of Health Services collects data, aggregated data on the number of clinic visits for influenza-like illness. So people who come in with cough or fever or body aches, who may or may not have necessarily been diagnosed with influenza, but in most years, these past years are different, but in most years, the vast majority of people who come in with cough, fever, and body aches have flu. Like, that's just usually what it is. So without having to do flu tests in these people, which are expensive and time consuming and don't necessarily help with clinical decision making, instead of having to get flu tests on all those people, right, we can just say, oh, well, we have this many people who had symptoms that were consistent with influenza, so that was probably influenza. And that's how we get a sense of how big our influenza outbreaks are every year. Seventh is social media. And so the example I'm going to share is actually just internet data rather than social media, but looking at what's trending, you can actually get a good idea of what's going on with people. So this excerpt here is from, there's an epidemiologist, Dr. Caitlin Jetelina, who's an epidemiologist in Texas, who has a public-facing website, Your Local Epidemiologist. She's brilliant. She does a really great job presenting the recent evidence as it comes and explaining it about COVID and what we know and what we don't and what the data shows. So if you're interested, I highly recommend you subscribe to her newsletter, or you can follow her on Facebook. But this is a snippet from one of her recent posts and talking about how now that more people are doing rapid tests at home for COVID, those test results don't necessarily get reported to public health, right? So COVID is a reportable disease. So if you get diagnosed through a clinic or through the health department, certainly, that result gets reported to the state data collection system. If you do a self-test at home, unless you then call your doctor or call the health department and let them know, that data doesn't get captured anywhere. So you may test positive, but that doesn't get captured in our statistics, right? The second S doesn't get captured in our statistics. So what she's talking about here is how now that a lot of people are doing home tests, we don't necessarily know how many cases there actually are, as many of them are going unreported. So she says, we also don't have a good grip on how the increasing popularity of antigen tests, those rapid at-home tests, are going to change our trends in terms of numbers of cases either. Not all of those who test positive for antigen are going to go get a PCR, which would be a test through a clinic that gets reported, right? And so these cases will go unreported. She says, but we do have anecdotal evidence that more and more people are testing. So we have empty store shelves, the stores are running out of the tests, long testing lines, and interestingly, in the Google data. So the word combination COVID testing is trending higher than COVID vaccine or COVID booster for the first time during the pandemic. So it gives us kind of a little pulse on what's going on with the population at large. So those are our 7 S's. And here they are all together, right? So we have a single case or a small series, which can be really useful, but is only preliminary information. Lots of types of statistics that we collect, everything from vital statistics to reportable diseases to accident and injury and police reports. We have survey and sampling projects that go out and routinely sample the health of the population. Self-reports, right, which we are, with the big caveat, we have to take all of those with a grain of salt. They need further investigation and verification. Sentinel monitoring, those early warning systems. Syndromic surveillance, where we just look for constellations or patterns of symptoms rather than a specific diagnostic test result. And then using social media or other internet searches to help us know what's going on. Okay. So what metrics or information do we use to measure the health of a population? So this was actually one of those questions, those on that initial thought questions, pre-course quiz. And some of you knew about some of these and a lot of you didn't, and that's to be expected. You haven't worked in public health. So what are the kinds of things that we look at? So historically, one of the most important indicators has been infant mortality rate, because historically it was quite high. So as you can see in the graph here, back in 1915, right, mortality rate was 100 per every 1,000 live births. So that meant 10% of infants did not survive the first year of life. That's really, really high, right? If 10% of your population is dying before they even hit 1 year old, that's huge. We've seen huge decreases in infant mortality over the last 100 plus years due to antibiotics, vaccination, sanitation campaigns, and nutrition campaigns primarily. And so our infant mortality rates are now quite a bit lower. They're still higher than we would like. But so we don't use this particular metric quite as much anymore because it's not as powerful. And some of the things nowadays that are leading to infant mortality are also leading to mortality in young children. So we tend to use more now the child mortality rate, so looking at the share of children that survive after the first 5 years. So those first 5 years tend to be particularly vulnerable, usually due to infections. So that's the primary killer for the most part of young children. Their immune systems are immature. They haven't been exposed to things before. They don't have natural immunity yet. But of course, we've made great strides again here as well with vaccinations, antibiotics, sanitation campaigns. So we can see a huge decrease globally in the child mortality rate, which is fabulous, right? But this is the number we use now because infant mortality rate is so much smaller. On the other side of the coin, we also look at how old you're likely to be when you die. So life expectancy is a measure of the average lifespan. It's not an accurate predictor for any one individual, right? This is the average. And in itself, it doesn't describe the quality of that life, right? So you can see Japan has the longest life expectancy. United States trails behind by about 4 years or so. And we are behind a lot of other industrialized nations, but ahead of some others. So there's been some interest in saying, well, okay, well, maybe this is how many years of life you have, but what if the last 10 years of that life you're demented, you don't even know who you are, you're living in a nursing home, or you have terrible lung disease and kidney disease and you're kind of confined to your bed and you can't do very much. So there was interest in kind of figuring out a way to describe the quality of life that people have. And so that resulted in this metric called the HALE, or the Health Adjusted Life Expectancy. So this is incorporating a number of categories to get a measure of the overall quality of your health. Now, when you think about the quality of your health, and this was one that hung up a lot of you on the thought questions too, is like, what does that mean to be healthy? Right? And so the WHO has decided that the following factors contribute to one's overall health. So your mobility, your ability to get up and walk around and move around independently. Your cognition, right? Your ability to know who you are and where you are and engage in the world as opposed to having dementia, for example. Self-care, or ADLs. ADL stands for activities of daily living. Can you care for yourself? Can you prepare your own food, feed yourself, bathe yourself, do your toileting independently by yourself, right? Your ability to care for yourself. When we talk about self-care in this context, we're not talking about like taking a bubble bath because it's been a stressful day, right? We're talking about, can you do the things that you need to do just to support your life? Then pain, looking at pain, because that can have an enormous detrimental effect on the quality of your life, your mood, and then your sensory functions. So can you see, can you hear, can you taste, can you smell, all those things. So the HALE is kind of a measure of how many years of good health you are likely to have. So you can see for the United States, for example, in the chart on the left, our average life expectancy is about 79 years. But our HALE is about 69. So on average, most Americans can expect to have about 69 years of good health and then another 10 years of not so good health before you die. And what you'll see is that for many of these countries, there is that kind of 10 years of not so good health before the end of your life. That's relatively consistent. A final measure that we use to look at the health of a population is the disability adjusted life years. So this is a way to kind of qualify or quantify the impacts of specific diseases or conditions on somebody's overall health. So if this sounds familiar to you, it should, because that's what we were looking at when we were looking at causes of disability using this website that I had you do some earlier activities looking at. And so looking at what are the things that contribute to decreased function in people's lives, right? So just being alive is not enough. We want you to be healthy and thriving. So what are the things that interfere with that? And I thought I would kind of just show you a difference from one of the questions that I assigned you. So I had assigned you for ages 5 to 14 in the United States, what was a major cause of disability in children. And the biggest one at that time for the United States was asthma. Now, this graph I'm showing you is globally. So what you can see is globally, the things that affect the health of children are quite different. Let me get my pen here, right? So we can see diarrheal illnesses are huge. Iron deficiency, for a variety of reasons, is really huge in terms of causing disability in children. Typhus and paratyphus, HIV, right? So these are all infectious diseases, malaria. So in many parts of the world, infectious diseases are the leading causes of disability and death, right? And it all has to do with those things I've kind of been talking about already quite a bit. So vaccines, antibiotics, sanitation measures make big differences.